inflammation. Hello, can you hear me? Okay. So
Yeah.
this is the right thyroid nodule. The left inferior thyroid nodule has another nodule. It's 1.6 by 1.5 by 1 centimeter. This nodule also has peripheral calcification and was categorized by the radiologist as TRAD 4. Again, they did a biopsy sometime in September last year, and the result was atypical according to the pathologist. And the description was cellular sample of atypical hyperplastic follicular epithelium arranged in microfollicular pattern. A follicular neoplasm cannot be excluded. So when I saw the report, the patient came with a biopsy report already. So I advised her that she need to have, at least, partial thyroidectomy, if not total thyroidectomy, because thinking that microfollicular pattern is usually associated with papillary carcinoma, although there was no description of nuclear abnormality. But, even though it said follicular neoplasm cannot be excluded, there was no description whatsoever of nuclear abnormality. And she does not have a stellar family history. Her mother has mantle cell lymphoma. Her father has widespread cancer of unknown primary. Her grandmother has inflammatory breast cancer. And her younger sister has a papillary carcinoma of the thyroid with widespread metastasis in the cervical lymph node area. So I advised the patient that, she really need to go for surgery. She agrees, and so she went to the surgeon. Ooh, now it's not moving. Okay. So the surgeon said, "Why do you want to have thyroid surgery? It's just 20 to 30% chance that this will turn out to be malignant. After all, you're just 39 years old. There's time to figure out whether this is going to be malignant or not. So, yeah, why don't we wait for 6 months to see if it is going to grow?" What happened though is this patient keep on coming back to my clinic having panic attack about her cancer. She assumed it's a cancer. One day she came in with, hand tremors. Another day she came in with sore throat, etc. I keep on telling her, you go back to the surgeon and tell the surgeon that take it out. Anyway, the surgeon waited for actually 9 months before repeating the biopsy. Again, the pathologist wrote, it's suspicious but not diagnostic for malignancy. The pathologist may be irritated because he said atypical follicular epithelium present, a neoplastic process cannot be excluded by light microscopy. But this time, the surgeon sent the patient sample for genomic testing. She tested negative for BRAF mutation, the valine to glutamic acid substitution for amino acid 600, which was negative, and RET PTC1 and RET PTC3 rearrangement was also not detected. By the way, this is the most common genetic mutation associated with radiation exposure in the Chernobyl population. So according to the Afirma genomic testing, which is routine here in the clinic, I usually get a fourth sample for this. And it said the risk of cancer is about 50%. So finally, the surgeon was convinced to do total thyroidectomy. And this is the result of the pathology report after surgery. Multicentric bilateral papillary carcinoma, a little bit of follicular carcinoma, and the third component is poorly differentiated insular carcinoma. The sizes of the papillary carcinoma is 1.3 centimeter on the right, 2.5 millimeter on the left. The follicular carcinoma was just 4 millimeter. The poorly differentiated carcinoma was the nodule that was sampled twice, and it's 15 millimeter in size with capsular invasion. There's no lymphovascular space invasion. On the papillary component, there's no tall cell differentiation. The margins are free. There was no lymph node submitted to the pathologist. So, in addition, she has follicular adenoma and nodular hyperplasia. So she called the clinic wanting to have an early appointment because she had a horrible pathology report, she said. And I called the pathologist, "Are you sure it's not anaplastic carcinoma?" I've never heard of poorly differentiated insular carcinoma. And the pathologist told me, "It's my first one after I've been a pathologist for 30 years." So it's that uncommon. So what is poorly differentiated thyroid carcinoma? It was first described by a German scientist in 1907, and he called it Wuchern-de-Struma, or a thyroid carcinoma with insular growth pattern. And he actually made an illustration of this, and it looks like a eyelet to me. And this is the actual typical insular thyroid carcinoma. And it's not until 1963 that Granner and Backwater introduced the term of poorly differentiated carcinoma of the thyroid gland into the English literature. Then in 1983, a Japanese group described the frequency of poorly differentiated thyroid carcinoma at 14% in their series of 258 thyroid cancer. And in 1984, another group reported that they have found 25 cases of poorly differentiated thyroid carcinoma. And in 2006, the Memorial Sloan Kettering Cancer Center proposed a definition for poorly differentiated thyroid carcinoma, and they described just two criteria. The first is the presence of mitotic index of over or equal to 5 per 10 high-power field of microscope on the slides, and the presence of tumor necrosis in the carcinoma. And they described that in their cases, the overall survival of 60% at 5 years. Then in 2007, a group of investigators, mostly pathologists and some scientists, congregate in Turin, Italy, and come up with the diagnostic criteria for poorly differentiated thyroid carcinoma. They describe the morphology as being solid, trabecular, and insular growth pattern, absence of nuclear features of papillary thyroid carcinoma, and having one or more of the following features, including convoluted nuclei or folded nuclei, mitotic index of 3 or more per 10 high power field, and presence of tumor necrosis. So, the tumor, what do they mean by the insular, solid, or trabecular growth pattern? This is typical of the insular growth pattern. It's a tightly packed island or nest of cells. Trabecular growth pattern means it looks like the sinusoidal pattern that mimics that of normal liver. It looks like liver actually. And presence of tumor necrosis. Another illustration is this. So insular pattern is a pack of, tightly pack of nests of cells, or trabecular pattern is like the liver pattern, or you can have solid pattern. Presence of necrosis, mitosis like here, okay. And then the worst version would be an oncocytic pattern on the cells in which they have, the cytoplasm is it's bigger. Again, this is an example of a solid growing tumor with extensive necrosis. Usually it grows around a blood vessels. This is typical of like malignant melanoma. Melanoma tends to grow around blood vessels. And this is, the tumor nuclei are small and round, and they do not have the abnormality of papillary carcinoma. In terms of immunostaining, okay. So these are for medullary, papillary, follicular, poorly differentiated, and anaplastic thyroid carcinoma. The immunostaining pattern appears to be more nearer anaplastic than the differentiated thyroid carcinoma. For example, thyroglobulin stain is positive or negative compared to follicular or papillary thyroid carcinoma, and the presence of thyroid transcription factor could be there or not. And in anaplastic, there's no, it's negative usually. So, how does the World Health Organization classify thyroid cancer these days? This was published in the Endocrine Metabolic Clinics of North America in 2019. So in the 1950s, the benign tumor of the thyroid are the follicular adenoma and papillary cystadenoma. Papillary cystadenoma are the hot nodules that we see on multinodular goiter. And the malignant thyroid cancer are either differentiated or undifferentiated. So the differentiated one are either follicular or papillary carcinoma. Anaplastic is the only undifferentiated type of cancer. But by 1992, poorly differentiated thyroid carcinoma or insular carcinoma was added to the list of malignant tumor of the thyroid. Then in 2017, the World Health Organization changed their definition of how thyroid neoplasm has to be categorized. The benign one is the follicular adenoma. Borderline one or uncertain one is the hyalinizing trabecular tumor, or the follicular tumor of unknown malignant potential, well-differentiated follicular tumor of unknown malignant potential, and the non-invasive follicular thyroid neoplasm, this one. In terms of the malignant tumor, the papillary thyroid carcinoma is now categorized as classic papillary carcinoma, the follicular variant, which we see a lot, the encapsulated variant, the papillary microcarcinoma, which we were supposed to ignore and monitor only without going straight for surgery, the columnar cell variant, and the oncocytic variant of papillary thyroid carcinoma. And the follicular cancer could be minimally invasive or angio-invasive or widely invasive. And then here's the Hürthle cell carcinoma. And again, the poorly differentiated thyroid carcinoma is included in the list and followed by anaplastic thyroid carcinoma. So what is poorly differentiated thyroid carcinoma? So it's an uncommon type of follicular cell-derived carcinoma. So it's compared to parafollicular or C-cell type neoplasia of medullary carcinoma. It's the same as follicular or papillary carcinoma because it's derived from the follicular cells. The incidence report varies according to the countries or varies according to how careful you look at the slides. It's mostly 1 to 3% in the United States, but in other countries it's reported to be 3 to 15%. In a study by Mayo Clinic, they reviewed over 3,000 slides and they only found 1.8% incidence of poorly differentiated thyroid carcinoma. In northern Italy, it's 6.7%, and in most of Europe, it's between 4 to 7%. The prognosis is between well-differentiated thyroid carcinoma and anaplastic carcinoma. The 5-year survival rate mortality has been described as between 38 to 57%, and the median survival is just 3.2 years. It usually affects patients in their late 50s. There's a higher male-to-female ratio, so 1:1.6, this is for female, compared to differentiated carcinoma of the thyroid, which is 1:3. Regional metastasis occur in 36% of the patients, and distant metastasis occurs in 26% of the patient at presentation. And the metastases are common. It's either in the regional lymph node, the liver, or the bone. The prognosis is poor. 25% of patients died of their disease. This is a 10-year follow-up. 29% were alive with evidence of disease, and 41% had no evidence of disease. So this is not a good cancer to have. So the theory behind the development of poorly differentiated thyroid carcinoma is it probably evolved from papillary and follicular carcinoma. With additional development of genetic mutation, you will then go to poorly differentiated carcinoma. Probably it accounts for most of the radioactive iodine-resistant thyroid carcinoma. And with more mutation, it can go to anaplastic carcinoma. So, Most of the poorly differentiated thyroid carcinoma arise from well-differentiated thyroid carcinoma, although a small subset do arise de novo. So, many times you can see the poorly differentiated carcinoma component within a slide of other carcinoma like papillary or follicular carcinoma. So about 80% of poorly differentiated thyroid carcinoma have poorly differentiated component of more than 50%. Only 20% have minor poorly differentiated component. However, the prognosis does not change. All it takes is for you to have 10% of the thyroid cancer to be poorly differentiated for the prognosis to be as bad as somebody with 100% poorly differentiated carcinoma in terms of the relapse-free survival or overall survival. It's actually the most common cause of radioiodine refractory PET-positive thyroid cancer, as defined by mitosis and necrosis. The problem is it's very difficult to make the diagnosis by FNA, in fine needle aspiration. Only 27% of cases were diagnosed correctly as poorly differentiated thyroid carcinoma on FNA. Most of the cases, as with this lady that I described, were put into the category of follicular neoplasm. And a meta-analysis study by Saglietti showed what to look for to make the diagnosis of poorly differentiated thyroid carcinoma on FNA. You look for presence of insular or solid architecture, hypercellularity, high nuclear to cytoplasmic ratio, and high mitotic index. These are the categories that will make it for you to categorize the cancer as poorly differentiated thyroid carcinoma. Again, in terms of FNA, there's a lot of common features with the differentiated thyroid carcinoma. For example, like this lady, you could have microfollicles in follicular variant of papillary carcinoma. And with this lady that I presented, she also presented with microfollicles, which I interpreted as being a papillary carcinoma. And they have round cells with high nuclear to cytoplasmic ratio. They also have nuclear overlapping like papillary carcinoma, but they do not have the nuclear features of papillary carcinoma, which is irregular nuclear membrane, presence of grooves, and inclusion. Instead, they have, necrosis and apoptosis. They have abrupt nucleomegaly, meaning you will find in the slide suddenly one cells will have a particularly big nucleus. And they have very little colloid, and the colloid pattern is also different compared to papillary carcinoma. This is more diffuse and smooth. This is more dots, a lot more dots, so it's a different pattern of colloid distribution. What about the prognosis? This is a study done from Brigham and Women's Hospital. They have 47 cases of patients with poorly differentiated thyroid carcinoma, and they found that the prognosis is dependent whether the patient has follicular capsular invasion has focal capsular invasion, vascular invasion, extensive vascular invasion, and widely invasive morphology. What they found is for patients at 5 years to have disease-free survival, 83% of patients with focal capsular invasion will still be disease-free at 5 years, and 100% of patients with focal vascular invasion will still be disease-free at 5 years. But once you have extensive vascular invasion, on the Kaplan-Meier chart is 57% of the patient will have disease-free survival once you have extensive vascular invasion. And if you have a widely invasive sample, only 10% of patients will have disease-free survival at 5 years. So the prognosis is really not good with this type of cancer. I hope with this patient, which has only focal capsular invasion, that she'll have this type of features, you know. And there is an oncocytic variety of poorly differentiated thyroid carcinoma in which the cytoplasm is bigger and they have poorer prognosis compared to the ordinary poorly differentiated thyroid carcinoma. And this is the disease-specific survival for patients with extensive invasion. Most, about 50% are dead at 10 years. So what are the molecular mechanisms that lead to development of poorly differentiated thyroid carcinoma? We know that two main signaling pathways involved in development of thyroid cancer is the MAP kinase signaling pathway and the PI3 kinase AKT pathway. The most important is the point mutation in the RAS and BRAF gene. The mutation in the BRAF gene is associated with papillary carcinoma. Mutation in the RAS gene is with follicular carcinoma, and some of the tyrosine kinase rearrangement, this one, RET-PTC, is most common in radiation exposure, with history of radiation exposure, like in the Chernobyl patients with thyroid carcinoma. So, again, for follicular thyroid carcinoma, the most common mutation is the RAS gene. For papillary thyroid carcinoma, the most common mutation is the BRAF gene. In order for poorly differentiated thyroid carcinoma to develop, in addition to RAS and BRAF mutation, you usually get more additional mutation. In particular, the mutation involved is the TERT or telomerase reverse transcriptase promoter mutation. So this is the TERT mutation, which is the most common mutation in poorly differentiated carcinoma. So you usually have at least two mutations when you go to poorly differentiated carcinoma. And when you get additional mutation, especially in the tumor suppressor gene P53, then you develop the anaplastic thyroid carcinoma. In children has been reported to also get poorly differentiated carcinoma, but for some reason their mutation is very different from that of adults, and it's the mutation encoding the metal ion binding sites of RNS3B domain or of DICER1. So DICER1 is the most common mutation in children when they develop the poorly differentiated thyroid carcinoma. Again, this illustrates the genetic mutation involved. For papillary carcinoma, the most common is the BRAF mutation, 60% of which is the substitution of valine to glutamic acid in amino acid 600 of the BRAF gene. RAS mutation is less common with papillary carcinoma. And with follicular carcinoma, the most common mutation is the RAS mutation. And for poorly differentiated carcinoma to occur, the most common is the third mutation. Again, it's the telomerase reverse transcriptase promoter mutation. And there's much more mutation involved for poorly differentiated thyroid carcinoma to occur. And for anaplastic carcinoma to occur, usually you have to have involvement of the p53 gene user. So this is a summary of the clinical characteristics and prognosis published by the Thyroid Journal Thyroid in 2019. Comparing the differentiated thyroid carcinoma, poorly differentiated thyroid carcinoma, and anaplastic thyroid carcinoma. They're all derived from follicular thyroid cells. The prevalence is 90% for differentiated thyroid carcinoma, 2 to 15% for poorly differentiated thyroid carcinoma, depending on how carefully you look at the specimen, and 2% of thyroid carcinoma are anaplastic. Most of the diagnostic criteria for poorly differentiated is the cytology based on Turin criteria, or the proliferative grading based on the Memorial Sloan Kettering Cancer Institute criteria. In terms of clinical characteristics, the people who develop differentiated thyroid carcinoma are younger. Female to male ratio is 3:1. With poorly differentiated thyroid carcinoma, its average median age is 59 years old. Female to male ratio is 1.6:1. With anaplastic thyroid carcinoma, it's usually older folks, and female to male ratio is about similar as poorly differentiated thyroid carcinoma. 69% of patients on initial presentation has extrathyroidal extension with poorly differentiated thyroid carcinoma, compared to 21% of patients with differentiated thyroid carcinoma. And 50 to 85% of patients has lymph node metastasis, and 85% of patients will develop distant metastasis. So again, the prognosis is very bad, but not as bad as anaplastic, because anaplastic, once you found it, it's all stage 4. Even if it's localized to the thyroid gland, it's categorized as stage 4. In terms of predictors of poor prognosis for poorly differentiated thyroid carcinoma is age over 45, T4A pathological stage, extrathyroidal extension, the number of mitosis and necrosis, and the presence of distant metastasis at presentation. Hopefully, my patient will not have that type of prognosis. Management is controversial because it's not a very common tumor. There's not much data on it. The surgery should include total thyroidectomy with central or lateral neck dissection if clinically or radiologically suspicious lymph nodes. And one thing I regret is I did not do any neck ultrasound on my patient, even though I felt a lymph node on the left neck. It turns out that's a 3-centimeter lymph node on ultrasound, which I sent the patient for after surgery already. And there's no standardized guideline for management of poorly differentiated thyroid carcinoma at present. In terms of outcome, okay, for poorly differentiated thyroid carcinoma, it's intermediate between differentiated and anaplastic thyroid carcinoma. So 5-year overall survival is 62 to 85%. 5-year disease-specific survival is 66%. And distant disease represents the major cause of death. Again, in terms of gene mutation, not only do you have the differentiated type of gene mutation, including the BRAF and the RAS, but third promoter gene mutation is very important for development of poorly differentiated thyroid cancer, whereas for anaplastic, majority have the tumor suppressor p53 gene mutation. So, in summary, what we have to think of when we see thyroid neoplasm, there's genotype and phenotype correlation between papillary cancer and BRAF mutation, and between follicular neoplasm and RAS mutation. And it's always hard to determine whether the follicular tumors are benign or not, if they do not have nuclear atypia or, cytologic atypia, and they don't have minimal vascular or capsular invasion. We usually categorize them as benign, whereas if they have invasive tumor, it can go as bad as aggressive invasive tumor or angioinvasion. So this is probably one category which happened to this patient. The surgeon told her it's 20 to 30% risk. Why should you have it taken out immediately, In terms of benign tumors, not all papillary structure is papillary cancer because the hot nodule or subclinical hyperthyroidism, or, sorry, Dr. Winter, clinical hyperthyroidism could be also presenting as papillary architecture. And these are hot nodules that are benign. And their mutation is different. They have unique mutation in the TSH receptor signaling pathway. And with papillary carcinoma, it could be indolent microcarcinoma in which, you subject the patient to active surveillance, or it could be invasive carcinoma that requires surgery and radioactive iodine treatment, keeping in mind that papillary carcinoma now come in different form. You could include a hobnail, tall, cell, or columnar variants. These are all with additional genetic mutation that makes it a more aggressive tumor. And with additional mutations and rearrangement, in particular, the changes in copy number variation in the chromosome, it gives rise to poorly differentiated and anaplastic carcinoma. In other words, most of the papillary and follicular carcinoma have diploid chromosome, whereas poorly differentiated and anaplastic carcinoma could have many, many copies of the chromosome. So that's one clue to how poorly differentiated the cancer is. Sorry, I have to keep on moving. Okay, so in summary, poorly differentiated thyroid carcinoma is defined by two histologic criteria. The Turin criteria would say you either see a solid nodule, a solid morphology, trabecular, like in the liver, or insular growth pattern, tightly packed nests of cells. They do not have the nuclear feature of papillary thyroid carcinoma, and they could have one of the following feature: convoluted nuclei, meaning it's a folded nuclei, high mitotic rate, and the presence of tumor necrosis. The Memorial Sloan Kettering group has different criteria. They look at high mitotic rate and the presence of necrosis. So in poorly differentiated thyroid carcinoma, you can have BRAF mutation, 19 to 33%. You can have RAS mutation in 5 to 28% of the cases. And if you have the BRAF, the most common BRAF type of mutation, it's more correlated with the Memorial Sloan Kettering criteria, and it's correlated to higher rate of nodal metastasis. And if you have the RAS mutation in a poorly differentiated thyroid cancer, it tends to jibe with the Turin criteria, and it has a higher rate of distant metastasis. And the most important thing to remember is expression of thyroid-specific genes related to radioiodine avidity was found to be lowered in the BRAF-mutated poorly differentiated thyroid carcinoma. The most common genetic mutation is the telomerase reverse transcriptase promoter mutation, which is found in 33 to 40% of poorly differentiated thyroid carcinoma. And there's high chromosome copy number alterations in poorly differentiated compared to differentiated thyroid carcinoma. Again, the reason this is missed most of the time, most of the publications are retrospective. They categorize the patients as having follicular or papillary carcinoma and did not specifically look for features that would suggest that the patient has poorly differentiated thyroid carcinoma. And it's only after the clinical course of the patient is unusual for differentiated thyroid carcinoma that people start looking at the slides, going back to their slides, and found that actually patient has poorly differentiated thyroid carcinoma. So, ATA guidelines for poorly differentiated carcinoma said recommend radiological studies including CT scan of the neck and PET scan for initial staging and monitoring of this cancer. In terms of treatment, what happened to the 47 patients at Brigham and Women Hospital series are the following. 98% of the patients underwent 1 or 2-step total thyroidectomy. 62% received radioactive iodine therapy. 7% had radioactive iodine therapy and external beam radiation therapy. 12% has a combination of radioactive iodine, external beam, and targeted therapy. Targeted therapy are mainly the tyrosine kinase inhibitor. 2% has radioactive iodine therapy. Chemotherapy, there's only one chemo agent, doxorubicin. that is used for metastatic thyroid cancer and external beam radiation therapy. 2% has different combinations, so it depends on how desperate the spread is going on. You either use radioactive iodine, and the suggested dose for radioactive iodine is actually higher than normal. This lady received 106 millicurie, even though the radiologist was telling me maybe we should go for 150. I said, no, let's stick with 106 millicurie because I did not know better. But it turns out that may be a good idea because she then developed lacrimitis, and I was crying all the time, and we had to send her to the ophthalmologist. I don't know what the ophthalmologist did, that it eventually resolved in 2 weeks' time. So, Kelly wants me to, remind everybody that today's event code is 1281362, for CME purpose. Now, in this lady, I think, we after the radioactive iodine therapy, I then palpated the lymph nodes appear to be enlarged. One by ultrasound is 3 centimeter. The other one is 2 centimeter. So, but there's fatty hyla at present, so I'm hopeful that it's not going to be a problem. But, she was referred to the tumor clinic at Vanderbilt University. First, I refer her to our oncologist here in Owensboro, who then referred the patient to Vanderbilt University, and they suggested that, additional radioactive iodine therapy, although this type of tumor is usually associated with radioactive iodine resistance, but it's still, the traditional treatment still holds, and they're going to schedule the CT scan and the PET scan after a month. Any questions? Did I make everybody sleep now?
Hi, Dr.
No, you're fine. Hey, Betty, there is one question a couple of questions here on the chat.
Okay.
So the question is, this is from Girish. Is clear and informative presentation. Did the 39-year-old case have a mutation in the TERT gene?
Third promoter gene.
Uh-huh.
No, apparently it's not a routine test for Afirma, so the Afirma representative is coming next week to my clinic to explain what kind of analysis they did. But apparently all they say is approximately 50% of being malignant. That's their highest, that's their standard. When they say it has to be taken out, it's 50% chance.
And
so
in which chromosome is the TERT gene?
I don't know which chromosome. I read it somewhere, but I did not remember where is it from. But definitely, it's not routine for Afirma. I think the university used a different company. I wonder if they do the third mutation then.
We use the Thyroseq.
Tyrosine kinase inhibitor?
No, Thyroseq. SEQ, Thyroseq.
Oh,
That's the
Thyroseq.
newer one, yeah, compared to
okay,
Afirma and Veracyte.
No,
So, Dr. Villafuerte, that's a great case. The first case that I saw of that insular variant carcinoma, if you remember, Hope Taragosa was our fellow. We had a patient at the VA, and and she presented in the 88 in 2012. And since then, we tried tyrosine kinase inhibitor. He developed DVT, then he went on lenvatinib. He continued it on his own, and then most recently he's developed lung mets and bone mets. And I mean, he's now 11 years. When I
Okay.
remember Tuttle came to her poster and said 5 years max. Beyond that, survival is going to be hard. That was 6 years ago. That was
Okay.
10 years ago. And now he's still, I mean, he's weaker and he has issues, but this
Still
person has the
survive.
third promoter, and I
Uh-huh.
think they're going to use the targeted therapy with one of the
Uh-huh.
new agents, Vitraqui or something like that. So for a NTRK1 mutation fusion, whatever that is, the genome finding. So yeah, but
Okay.
he had the
Okay.
third promoter, so very interesting case.
That's good. This is my first case. The pathologist, I said, are you sure it's not anaplastic? He said,
No, this
no.
is intermediate between anaplastic and
Yeah,
well
yeah.
differentiated.
We
Yeah,
don't,
it's
yeah.
they used to call it tall columnar, but now it's more called the insular variant. So yeah, that was my
Mm-hmm.
first time 10 years ago. So
Yeah.
yeah,
Okay,
very
so it's
interesting.
uncommon, but
Very
mostly
uncommon.
it's
Yes.
a misdiagnosis.
hmm That's correct. Yes, he came to
Okay.
us from a different center. So thank you. That was a good review.
So Betty, I'll echo Shree's comment. That was very informative, and thank you very much for a lucid lecture. I was curious whether the post-operatively the thyroglobulin in the blood was positive or negative, and what you thought about the sister who also has
Yeah,
thyroid
yeah.
cancer.
So I told the pathologist to go back to the sister because the sister is 2 years younger, and it's not only one side lymph node metastasis, it's bilateral. So they had to do radical neck dissection on both. So yeah, he said he's going to look at the sister slides again to see what it is. But
But is
this
this
patient,
is this tumor known to be familial in any way?
no, there is no data on it. It's uncommon enough that there's no report of familial. But for some reason the whole family has cancer. So she's very worried. She's very aggressive. She's always in the door of my clinic trying to get in because she know her family history. And I was afraid to give her high dose radiation because I was afraid she'll get the lymphoma that her mother has, you know.
And what
So,
about the thyroglobulin level in the blood?
oh, the thyroglobulin was not really high. Not it was 5 point something. I can just look it up right now. It was less than 10 after surgery. So maybe but that's immediately after surgery,
Yeah.
So,
Our patients was as high as 5,000. It has
oh,
been
this
as high
one,
as 30,000 in the past. But then he
this
had
one,
metastasis.
I think 88 was the highest before
I see.
surgery.
Yeah.
Yeah.
Then maybe she has a good prognosis. It's
Yeah,
probably
maybe
maybe
she has
so.
good prognosis despite the 9 months wait for surgery.
Yeah,
Yeah, I was
maybe.
kind of sometimes, she requested that if she need additional surgery, I need to send her to Louisville. So Amy may end up having her too. Amy
Mhm.
just did a lot of my patient surgery if they request for second opinion, and all of my patients here in their 30s have nodal metastasis, all.
My goodness.
I had 6 cases, all of them
Mm.
32 years old, 34 years old.
Mm.
Everybody has regional metastasis.
Is
I
there
don't
like a
know.
nuclear reactor or something around that
No,
area?
no. They said they're in the uh, area where it's the Ohio Valley.
Valley.
And there's a
Mm.
lot of aluminum company, car company surrounding the Ohio
Mm.
Valley.
Now,
So
what is
they
their
said
mutations? Are they BRAF or did they have any other mutations?
no, I
Those
did.
patients.
I routinely
V600.
do affirm a sample,
No,
you
no, no.
know.
In your surgical pathology, sometimes if you send it, they are
No,
able to
they
run
don't do it
mutations.
routinely here.
Okay,
They only do it during FNA.
I see. Yeah, maybe
So they
Amy
don't.
should be able to get that through the.
No, that's the problem. Amy said it does not. They don't do it routinely at Norton
Oh,
for surgical pathology, but they do it
interesting.
for FNA.
I know, even for benign ones.
Yeah.
Yeah, yeah. So she's doing a lot of radical neck for my
Yeah,
patient,
yeah. That's crazy.
which is
Mm.
weird, you know. And the worst thing is the patient get the data before I have the time to review the slides. So they'll call
Mm.
and cry and said, I have papillary thyroid carcinoma on my biopsy
Oh
before
wow.
I call them.
Mm.
One more
Yeah.
question, Betty. You said that some of these lesions stain positive for thyroglobulin and some don't. And I wonder whether that might be a predictive factor and whether you stained this tumor for thyroglobulin to see if it was positive.
Yeah, so here they don't do immunohistochemistry in the path here. So yeah, some of them, and their thyroglobulin pattern is also different. It's dot and more scattered compared to the more congregated type of thyroglobulin staining with differentiated thyroid cancer. So actually, yeah, anaplastic, they don't even stain at all for thyroid
No, it's always
globulin.
negative. Yeah.
Yeah,
Mm.
yeah,
Yeah. It's de-differentiated, so.
yeah. I thought it's interesting because it's my first case of poorly differentiated. I
Yeah.
thought
Well, you'll
must
be
be
doing a
nothing.
lot of scans, and like Dr. Winter said, some of these de-differentiated, the thyroglobulin does not show up, and
Yeah.
uptake of scans, iodine scan, because of the sodium
Yeah,
iodide symposium. So you end up doing a lot of neck ultrasound, PET scans. I have one
yeah.
similar young patient
That's
in
why,
downtown. So yeah,
CT scan and PET scan is routine for
yeah,
after
and a very
surgery.
good neck ultrasound with lymph node mapping that also helps.
Uh-huh.
But those are very
Yeah.
interesting patients. Yeah, thank you for the
Yeah,
presentation.
that's true. Maybe it will be my first and last case of poorly differentiated thyroid
No,
carcinoma.
yeah, we have this patient 10-year history and he's still living, although most
Still
recently has
alive.
empyema. So the targeted therapy
Okay.
is something new. So
Yeah, unfortunately, the oncologists here do not do it. That's why she was being sent
Intervendi,
to
yeah,
Vanderbilt. And
that's
then
correct.
I told the patient, you're seeing too many doctors. I'm going to recuse myself. The patient said, don't you dare. You're the only one doing something about it.
Yeah, she's right.
So,
Thank you, Dr. Wee.
okay. Thank
Thank you.
you for all your, for sharing. Okay.
Thank you.
Bye. Thank you. Bye.
Thank you very much.
You're welcome. You're welcome. Bye.
Thank you, Dr. Reed.